So the next two is calcium. Okay, and the first one is hypocalcemia. First of all, with calcium, what's the thing that you have to think about right away? Albumin. And always calculate a corrected calcium, okay? Because you don't know. Let's say you're not able to calculate a corrected calcium, or your corrected calcium are not, you don't trust it. Is there another way? So you can actually measure the free calcium. So you can measure the free calcium, and this usually is either through an ABG stick or like another way, like just an IV, and you can actually measure if the patient is truly hypocalcemic or hypercalcemic. Okay. So hypocalcemia is very simple. There is no rules for hypocalcemia like hypokalemia. It's not the rules aren't as clear. It's not if you give like 1 gram you will increase. It could be something similar, but you don't worry too much about overcorrecting or like doing it too much. So what you do is for hypocalcemia, you just give calcium. Give calcium, and the calcium you're gonna give is, we talked about it, either calcium gluconate or calcium acetate or calcium chloride. Okay, and there's no right or wrong. You can give 2 grams IV. You can't really do PO. You just want to do IV. So what you can do is you just give the calcium. Okay. Now, hypercalcemia, it's a little bit more complicated. I think we switched here the style. We start with hypo and hyper just because it's less complicated. For hypercalcemia, it's really 2 parts of the kind of treatment. Okay, number 1 is you have to figure out the etiology of the hypercalcemia, because a lot of times you don't know exactly what's causing it, and what you're gonna give the patient is gonna depend on what's causing the hypercalcemia. And so hypercalcemia, you want to make sure it's actually high. So what you want to do is really check the free calcium, as I said above. So you can correct it based on the albumin, but really you want to make sure that you're treating hypercalcemia. And then number 2, after you figure out or try to figure out the etiology, is you want to treat. And the treatment there's multiple ways to treat hypercalcemia. The most important one is very simple: IV fluids. And it's really IV fluids, just IV fluids alone should be enough to treat your hypercalcemia, unless it's severe that requires more things. Okay. What are the more things that you can give for hypercalcemia? So I'll give you one of that. One of it is calcitonin. You'll hear about people giving calcitonin. Okay. So you can give calcitonin, but again, calcitonin will work pretty quickly. Most of the time you don't need to. Most of the time you're going to give IV fluids and your calcium is going to correct, unless the underlying cause is not corrected. Okay. Now, if you're in the realm of giving IV fluids and now you're giving calcitonin because it's not correcting well, at this point, once you start considering calcitonin, a lot of times is endocrinology is gonna be involved. Okay, because they usually deal with hypercalcemia, because a lot of times it's hyperparathyroidism driven hypercalcemia. Okay, now if the calcitonin doesn't work, then what else can you give? So you can give cinacalcet, which is another medication that will drive down the calcium by resetting the receptor, the parathyroid receptor. It acts on the parathyroid essentially, the calcium receptor. And then you can also give denosumab, which is an immunoglobulin, a monoclonal antibody against, I believe, rank ligand. And it essentially decreases the osteoclastic activity and decreases the release of calcium from bones. And so you get less calcium. And then if the patient has lymphoma, or the hypercalcemia is secondary to lymphoma, or secondary to sarcoidosis, or any granulomatous disease, or secondary to dystrophic calcification, secondary to malignancy, then what can you give?
Is it steroids?
Steroids, yes. Very good. Okay. Then you can give steroids. And this will drive... This is the only difference. This is the only difference in management of hypercalcemia, is if you have these specific conditions, you can consider giving steroids. Because steroids will decrease the influence of the macrophages or whatever cell that's producing the hypercalcemia. Remember, in sarcoidosis, for example, the hypercalcemia is because of overactivation of vitamin D inside the giant cells, the macrophages. And what happens is that you get hypercalcemia because of that in the granuloma. So that's one of the methods. Okay. This is it for hypercalcemia. The etiology you have to kind of investigate. But in terms of the treatment, it's really IV fluids, maybe calcitonin, and then steroids if needed. Okay, great. Let's talk about the last one, phosphate. Okay, so phosphate, again, you have hyperphosphatemia. What's the most common cause of hyperphosphatemia? When you see somebody with high phosphate, what is the thing that right away comes to mind?
Maternal nutrition.
Somebody said RF. I'm guessing renal failure. Yes, so CKD, chronic kidney disease, is the most common cause. Okay, in chronic kidney disease, what happens is you have something called tertiary hyperparathyroidism. So they will have high PTH, high phosphate. In fact, the PTH level and the phosphate level in CKD are predictors of prognosis. So a lot of people, every visit to the renal doctor, you'll get a phos level and a PTH level if you have CKD, because that will help you determine what to do with the hyperphosphatemia. So what are you gonna do with the hyperphosphatemia? So how are you gonna treat it? First of all, there's no urgency in treating hyperphosphatemia. You just need to treat it somehow. Okay? So what is the most common way of treating it is by using something called phosphate binders. Okay, these are chelators. These are like kayexalate for potassium, but these are for phosphorus. Okay, and the most common one is cevilamir. Okay, the other name for it is Foslo. Okay, there are others. There are other binders. I'm pretty sure now there is latest and greatest, but cevilamir is the big one that you need to know about, and to know the name even Foslo. Okay, the other thing you want to do for hyperphosphatemia, because these people will have tertiary hyperparathyroidism, is you want to fix that. The reason they have tertiary hyperparathyroidism is because they have severe vitamin D deficiencies and sometimes severe hypocalcemia that's sometimes not apparent. So usually these people, you will put them on vitamin D plus calcium, and this way you are essentially fixing the hyperparathyroidism. And technically this is it. And then you also want to put them on low phosphate diets. Again, hyperphosphatemia is something that's usually managed as an outpatient. As an inpatient, you might get a whiff of it, because if somebody has CKD and gets admitted, then you might, while you're taking care of them, the renal might be following, or somebody might following and telling you, hey, put him on sevelamer, start him on phosphate binders while they're in-house. Okay? While hypophosphatemia, so this is the one that's caused by essentially malnutrition. So you're talking about somebody who's chronically malnourished, or if somebody has been intubated for a long time, so prolonged intubation. Okay, so somebody who's been on the vent for a couple of weeks, you might worry about hypophosphatemia, and this is why in the ICU setting you want to measure the phosphate almost every day. You will measure the phosphate every day. What's the problem with hypophosphatemia? What do you worry about? If these people start eating, what are they gonna get?
Refeeding syndrome.
Refeeding syndrome, exactly. So you have to worry about refeeding syndrome for these people. So you really have to replete their phosphorus before feeding, okay? In terms of therapy, how do you replete phosphorus? Again, it's very easy. You can either give sodium phosphate, okay? Or you can give what we talked about earlier, potassium phosphate, okay? So I tend to think that potassium phosphate is not as good. Potassium phosphate, so K-phos, is not as good, is not as elegant to use as sodium phosphate. The only reason you would use K-phos, potassium phosphate, instead of sodium phosphate is if somebody is also hypokalemic and you're trying not to give them too much fluids. So then you would use K-phos, then you will kind of, target both at the same time. But in general, sodium phosphate would be the treatment of choice for hypophosphatemia.